terms of conservative management overall, and also rehabilitation of ankle injuries. Okay. So again, I'm actually practicing in UMMC, and a private wing will be the UMSC, senior medical lecturers. I'm also the vice president of Malaysia Institute of Sport Medicine. So me myself also an athlete, a coach, and also a technical officer for medical sports. So let's start with a case study. So we have this 21 years old badminton player that complained of right ankle pain and swelling for 5 days. Okay, he allegedly fell with his right ankle landed in inversions while performing a high jumping smash during a badminton tournament 5 days ago. He's able to obey the weight, but emulate the lifting gates. So he came to you, and then you examine. On examination, you reveal there is a lateral ankle swelling with tenderness, a positive anterior test, probably grade 2, okay? And otherwise, the target test, the squeeze test, the external rotation stress test, and constant test is negative. What is the most likely diagnosis? Is it A, calcaneal fibular ligament tear? Is it B, the anterior talofibular ligament tear, which is the ATFL tear? The C, synemosis injury, Achilles tendon rupture. Okay, there's actually okay. Which one do you think is it? Anyone? Can you put out your hand for calcaneal fibular ligament tear? No? Okay. How about, and B? Anyone? B? Okay, okay, last count is B. C, synemosis injury? No? B? How about Achilles tendon injury? Okay? Okay, so let's see what's the answer. So the answer is actually ADFL. Why is it so? So if you look into the history itself, it's a right ankle immersion sprain. Okay, so right ankle immersion sprain, the most common ligaments is actually the ADFL. Okay, so on examinations, you can actually notice that I actually point out, actually I already exclude the other three. Okay, if it's a CFL tear, the target will be positive. Okay, the target can be actually of either a lateral or medial ligaments, but it's actually more specific for the calcaneal ligament tear. Then the squeeze test, the external rotation stress test is more for synemosis injury. Then Achilles tendon is actually a Thompson test. Okay, so the answer is B. So okay, so he actually came to you. So he actually asking what is or are the most appropriate acute management for these athletes. Okay, regardless whether you are a physio, whether you are a GP, or whether you are a sideliner covering this badminton games tournament at the time. Okay, so will you apply ice compressions? Okay, yes. Okay, answer can be more than one. Okay, how about ankle brace?
Yes.
Yes. Okay. Prescribe topical analgesia? Not sure. Okay. Prescribe oral anesthetics? Yes. Okay. Normal bearing with crunches? Let's say just now we diagnosed this grade 2 ATFL sprain. Okay. Apply clinician aid. Okay. So there is actually some of the answers is ambiguous because there is no hard and fast rules for some of the answers because the evidence is still weak. So okay, my choice. This is my choice. Okay, ice compressions, yes. Okay, especially within acute injuries, within 24 to 48 hours. Yes, ice compressions, because it's going to reduce the edema, reduce the swelling, reduce the pain. Okay. Ankle brace, yes. Okay. Ankle brace can be just you don't have to use the hand walker, can be just ankle steel up, or even just the S60. You can have a look. The S60 ankle brace. Okay, the figure of 8. Okay, or can be just normal ankle wrap, because you want the compression effect. The compression will actually help to reduce the edema. Okay. Topical anesthesia, yes, I would say. Okay. You can actually apply topical anesthesia with because the topical, the effect is actually quite localized, and it doesn't actually cause much systematic effect compared to oral anesthesia. Okay, later I will explain why not oral. Okay, so the oral is out. Okay, and a lot of the topical anesthesia, okay, nowadays they doesn't contain NSAIDs, although they do actually act at the same pathway, some of them, but they have other alternatives other than topical NSAIDs. Okay, and non-weight bearing crutches, definitely no, based on the police acronyms that Prof mentioned just now. Okay, so this is my answer. Okay, so initiative, you apply? Actually, the evidence is not strong. Okay, 50-50. So I don't see if you want to give support, the initiative doesn't actually have that functions. But if you, let's say, you want to give the proprioceptions or mechanoreceptor effect, then initiative might actually produce some placebo effect, I would say. Okay, so I'm not a fan of initiative. Okay? So okay, when we look into this is applicable to rehabilitation, sport rehabilitation in general, not just ankle rehabilitation. This actually biopsychosocial. Now they add into this contextual model. Okay, this is proposed by Trunks in 2020. So when we look into athletes, okay, or any recreation persons that actually do exercise or sports, then look into first when he or she had the sport injuries. Okay, you have to look into the bio side, physical side, which is the body itself, actually sustain the injuries, and the psychosocial, which is the mental, okay, the cognitive, the behavior, the affective response to because of the injury, actually required recovery, and then the time lost from the injuries. He cannot play, he's very depressed, get isolated, okay. So all this is the psychological aspect. Then the third one is social aspect, because he definitely will get isolated if it is it's a team sport, let's say, okay. Then he will get this social aspect will also affect him, okay. And then contextual effect usually come from the structural or institutional systems. Example is, like let's say he is a national athlete, okay, and then he is going for the coming Asian Games. So actually the institutes or the national sport associations actually they actually warn him, okay, if you don't heal by this time, then you will get eliminated, you cannot participate. So that is the conception, that means the system itself that gives him the pressure. Okay, so we have to look into all these four. Okay, and for phases of rehabilitations also, I'm actually divided into 5. This is also applicable to overall sport rehabilitations. Okay, the first one is like we're no longer using price, okay, but I'm not 100% agree on that. But we still use the ICE plus the optimal early loading, which is the police. So the acute phase is usually the police, And then the acute also called the immediate phase, okay? Then we have the intermediate phase, which is the restorative and recovering phase. This is where we actually want the athlete to start doing the range of motion exercise, the strength, okay? And gradually expose back to the exercise regimes, and also to maintain, it's very important to maintain the general aerobic fitness, okay? And then we have when he actually can go and progress to the next phase, which is the sport specific or functional phase, okay? This sport specific phase, the athletes will expose to the like the normal strength training, functional training. So he will expose to the sport specific training, which is actually very related to the trainings that he later will, when he actually recover from the injuries, like examples football, okay, so then he will train on the drilling side, okay, the sport specific, and also the kicking, okay. So then return to sport actually is subdivided into return to, first is the return to the training, okay. So training can be partial training or full training, okay. So the partial training can be contact or non-contact, okay. Then returns to the sports, okay, that means returns to the games, okay. Then can be playing full game or half games, it depends on the player conditions. And then we have the returns to the performance or the pre-injury level. This is the ultimate aim that we want, because most of the time I found a lot of healthcare workers, especially when we're dealing with athletes, we only stop when they're able to return to training. Okay, so and the athletic knowledge also, they are quite, when they are not knowledgeable and they are quite limited, they will be frustrated because they're only able to return to training, return to sport, but they are unable to return to the pre-injury performance level. Okay, so this is what we aim for. So then, always remember, when there is always, when you have history of injury, especially ankle sprain, okay, that is like what Prof say, that is when it is not treated, 40% will get into chronic ankle instability, and then there's high risk also. Then you get into a risk of re-injury. So we have to have this injury prevention phase. Okay. So what will we do? Always continually specific management of the tactic. Okay, this is a strength and condition and coach part, and then assess the drill and exercise to optimize the performance and the functions. Okay, this is the 5 phases. So again, I took from the books, and Carnes. So they actually have this, like when someone has athletes sustain injuries, the phase 1 will be the acute management, which is the police. And then we have the phase 2, we have mechanotherapy, which is the optimal loading. And then you address the biomechanics when you know what is the underlying problems that cause the tissue damage, and try to alter the risk factor and maintain the general conditions, which is the cardiovascular fitness, okay, and alternate the trainings. That means if you are having ankle sprain, do you ask the patients to rest completely? No, you still can do upper body training. So there's so many types of aerobic upper body trainings that you can actually maintain the cardiovascular fitness. Okay, so the third one is to replicate the sport-specific demands. Okay, the sport-specific trainings. Okay, and then phase 4, return to sports, and when you're able to return to sports, return to the pre-injury levels, okay, and we try to prevent the re-injury phase. Okay, so I will go very fast this one because we will some repetitions. This one is actually based there's so many protocols, there's so many protocols. So this one is generally a summary of some basic principles that are applicable to lateral ankle sprains without any bony involvements. No bony fractures. This is lateral ankle sprains. Okay. So if it's a grade 1 or 2, okay, usually this is let's say this is a grade 2. The phase 1 will begin. So in rehabilitation, there is always two school of thoughts. You either you want to be time-based, based on, so you will actually, when the patient's having injuries, okay, let's say like ankle sprain grade 2, so if you are following a protocol, okay, you want to be time-based, or you want to be the goal-based, or whether you want the patients to, now we no longer looking at, because different individuals, their recovery and their response to injuries will be different. So it's actually not very relevant to based on time. Of course, time we will actually take it as one of our guides, but ultimately we want to have the outcome based. Okay, that means what actually have the patients achieve the criteria to progress to the next step or next phase. So the phase 1 basically is the protect the injury area and limit the tissue damage, and then relieve pain. They control the inflammation and swelling, and patient education play a very important role. So last time we have these eyes, and then we progress to eye. This is the eyes, and then we have rise, which is additions to eyes. We actually have rest, eyes, compression, elevation. Then we added on P, which is the protection. Okay, and then Professor also mentioned that now we are actually moving to the optimal loadings. So the optimal loadings is actually umbrella terms. Umbrella terms for mechanical therapies. Okay, doesn't mean that the patients have to 100% walk. It doesn't mean that the patient have to ambulate. Okay, it is a lot of pains. Patients are unable to actually walk or stand for very long. Okay, so what other optimal loading that we can actually advise? Okay, so the umbrella terms of this mechanical therapy actually also includes mobilizations and manipulations. So if you are an osteopath, if you are a chiropractor, the optimal loading is actually applicable by doing joint mobilizations and manipulations. Okay, because we want to increase the neovascularizations, increase the tissue healing, and increase the blood flow to the injured area. Okay, so of course we want to mobilize the patients as early as possible, early activities, because this will actually help in recovery. And eyes. Okay, eyes usually acute injury within the 24 to 48 hours, and we usually apply 15 to 20 minutes, not more than that. Okay, compression effect actually do help. That's why I suggested just now, we either use bandage or we can actually use the ankle wrap. Okay, and the elevations to actually reduce the tissue fluid back to the heart. Okay. Okay. Apart from police, anyone heard before this latest peace and love? So it's very contradictory. Okay. Now people say ice is not good. Okay. This peace and love say ice is not good. Okay. So why? Why do they say that? Okay. So the latest ones by this researcher called Douglas actually published in 2020. So he actually come up with this to treat soft tissue injury. Okay, we actually have to no longer using police. We have to use peace and love. Okay, so peace means first protections. So we avoid activities, movement that increase pain during the first few days after the injuries. Okay, so the protections can be by using the depends on the injuries, can be using ankle brace or ankle support, or even if the patient is someone very stubborn, don't like don't like to wear brace or always take out, then you can actually apply you can actually recommend the ankle hand walker, okay, this boat walker, okay, and then rest have to be as minimal as possible, okay, because we want to avoid prolonged resting, they actually cause muscle wasting and then muscle atrophy, okay, and then this will actually reduce in the optimal healing, okay, and then elevations, okay, elevate the injured site, which actually increase the interstitial fluid back to the heart, and avoid anti-inflammation. That means avoid taking, especially NSAIDs, because they actually propose that the anti-inflammation NSAID itself is actually very essential in healing. So we need the inflammations to set in, okay, and then the cyclooxygenase pathway and all that, so that the healing will take place. So if we stop the healing by giving NSAIDs, NSAIDs mean the anti-inflammation stuff, non-steroidal anti-inflammatory drugs. This will actually have a long-term side effect, which is there will be prolonged healing time, and actually patients then they will have redundant collagen synthesis and end up with the scar tissue formations. So they actually ask to avoid taking analgesia. But this one also up to the jurisdiction. If it's soft tissue, you can, but if the patient does not move at all because of the pain, you actually give. You still have to, because not moving, okay, because of pain, okay, is actually even more detrimental than this one, not giving painkiller. Okay, and again, there's apart from NSAIDs, there's also other type of painkiller which is doesn't contain NSAIDs. You can actually try that first. Okay, and avoid icing because they believe ice itself also stops the inflammation process. Okay, so this one, peace and love, is still debating among different school of thought. So it's actually when it comes to treating the patients, you have to be on case by case basis. Okay, and then compressions, yes, because you reduce the swelling. And education, this is important because what you want to educate, you want to let the patients know what conditions that he's having, have the mental preparations of how long the recovery will take place, and he have to prepare on. We have a time loss from the sports. Okay, so they also advocate that avoid unnecessary passive treatment. What is passive? What is active treatments? The passive treatments means things that not done by the patients, things that done by the physicians or the Health Alliance healthcare professionals. Examples, joint manipulations, okay, acupuncture, okay, surgery, okay, or injections, okay.
How about massage?
Massage also is a passive treatment. They say no. Okay, the most important is the active treatment. Educate active treatments, that means optimal loading. Ask the patient to move themselves. Because they actually advocate the healing to naturally take place. Okay? And they want to avoid all these over treatments. So this one is also very debatable. Okay? Because most of us actually, physio, we have to do something passively to earn incomes, to gain revenue from the patients. So if you don't do this, not doing this, all these present treatments, let the active recovery to set in, so we won't actually have patients. Patient can just self-healing if he actually educated enough. Okay, so this is debatable, but we know that active approach will actually is important. That means active moving and active rehabilitation can actually avoid 20 to 40% of developing the chronic ankle instability if it's after the lateral ankle sprain. Okay. Press next. Okay. So the peace is the immediate phase. Now we move to peace and love. So what is love about? Love is the subsequent phase after we done all the immediate phase. So again, L is the optimal loading. Okay, to let the pain actually is a very good protective mechanism. Don't you feel so? It's actually to help you to know when you should stop, when you are loading too much, and when you should actually go further. Okay, when you have pain, actually it's a protective mechanism for you to stop doing the exercise or the loading exercise that you are doing. Okay, so L is the loading. Optimization is important. Always tells the athletes, the patients, be confident, be positive, because what brains think and what brains are prescribed will actually affect the healings and also the recovery. Okay, so mental strength is important. Okay, and vascularization here actually means besides just stop from doing anything, we have to actually do some pain-free cardiovascular or aerobic exercise to maintain the general fitness. So example like what I mentioned just now, if it's lateral ankle sprain, lower limb is having pain, difficult to, unable to run, you can do the upper body like rowing, the arm ergometer, even swimming. Okay. And then the last one is that exercise to restore the mobility, the strength, the perceptions, and active approach in recovery. Okay, so again, so the plan is police. You can use the tape ankle brace to allow early gradual weight bearing for optimal loading. And then therapeutic exercise wise, we will advise the patient to do. If it's a lateral ankle sprain, okay, we can do range of motion exercise. Always start with range of motion exercise. Example like this picture is actually the ankle circles, except inversions. We don't do at the immediate phase. Okay, not the first few days, okay. And then always maintain the cardiovascular fitness, okay, by doing non-weight bearing exercise, example swimming, cycling, pool exercise, rowing or upper body ergometer. This one, the one here is actually a PAPS. Everyone know what is PAPS? Biomechanical ankle platform system. It actually can help. Patient can just step on it. It's just like a Uber board or rocker board. Patient can just step on it and do range of motion exercise. Okay. So the phase 2 is in the intermediate or the restorative or recovery phase. So in this phase, the goal is actually we have to try to restore as much range that we can achieve as possible, and then restore the muscle strength in all planes, which means that actually include the extrinsic and intrinsic muscle of the ankles, and then improve the neuromuscular control. So the plan will be to continue the police, especially we want to optimize the loading, okay, and then the exercise will include range of motion. So in this phase, we can do all three. Just now we try to avoid inversions and eversions because of the ankle sprain is inversion sprain. So this one we can do all sprain, all plane inversion, dorsiflexion, plantar flexions, strengthening the muscle surrounding the foot, including the extrinsic muscles and the intrinsic muscle of the foot. So example exercise that you can do, intrinsic muscles, you can ask the patient to do towel curls. You put a towel on the floor, ask them to use the, now it's difficult to find. Okay, so what I will ask the patient is to make a small pieces of paper ball and just drop on the floor and use the tools to pick and put inside the bottle. So this is a very good strengthening of the intrinsic muscles. Okay, and then don't forget about neuromuscular control. Okay, some of the exercise of neuromuscular control is by using the later I will show the balance board. Okay, and also the perturbations trainings. Okay, so what is perturbations training? Have you heard of perturbations training? So perturbation training is something that you actually you want to destabilize the patient. You want to make the patient not stable, okay, because you want to enhance the neuromuscular control. So how do we do that? So example will be, okay, so this is the closed kinetic chain, the leg press, leg strengthening. So this is some of the examples of a neuromuscular control exercise. You can actually always start with single leg, okay, single leg, eye open, and then with arm open, okay. Then only you ask them to the arm put down and try to close their eyes. Okay, there's a lot of different boards you can use. You can use form. You always start with a flat ground first, on the ground first. If it's okay, then you change to form. Then you can use BOSU ball. You can use the BAPS, the biomechanical ankle platform system, or even the Uber box, okay, or sometimes they call the rocker box, okay. So example of so this one you can actually modify. You want to introduce perturbations. So you ask the patient to step on these BAPS, the BAPS, this ankle platform system, and you as the physiotherapy or the doctor that treat the patients, you can actually you press on different direction so that you ask the patient to stabilize, okay, to actually so this will actually give them the stabilization stimulus and then enhance their control on the neuromuscular control on the ankle joints. Another good example is this BOSU. Okay, you will be moving and you ask them to stabilize. Try to, when you move to the right, ask them to move back. Use the ankle to move to the left. Okay, this is some of the perturbations. If patient is doing the functional exercise, let's say the patient is a badminton player, okay, you can actually ask them to step on a soft form and try to throw a ball, okay, throw a ball or catch a ball, okay, or let's say this is more on baseball, or hold a racket and try to catch a ball with the racket, okay, and then the functional exercise can also use the resistant tube, or you can use resistant band, okay, on the uninvolved. This is the injured leg. Okay, the injured leg can actually move forwards and also move backwards to actually train functionally. Okay. So we can also use I think later we'll have the workshop will actually teach you the Y balance test. Okay, the Y, if it's a Y shape, star expression will be a star shape. That means it will be instead of a Y, we will see an asterisk. Okay, the star asterisk shape. So this is also very good neuromuscular training. we can use for tests, can also use for training. Okay. Okay. So I want to talk about this concept again. So when the patients, let's say, we actually have this food call system. Okay, what is food call system? Food call system actually consists of the neural system, which is the receptor. Okay, example of the receptor which assists in the food includes the muscular tendinous receptor, the ligamentous receptor, and also the plantar fascia cutaneous receptor. Okay, so that is the neural system. Okay, so there is actually three subsystems. Just now I mentioned the neural subsystem. The other two is the active and the passive subsystem. Active subsystem includes the one which is moving, the dynamic. Okay, so in food, you think what is actually moving? What structure can be moved?
Joint.
Joint, yes. Okay, but when we talk about stability, when we talk about dynamic stability, what is it referred to? That is actually same with the active subsystem. Actually referring to the muscles. Okay, so the intrinsic and the extrinsic foot muscles is the active subsystem. So the passive subsystem will be all the static stability, okay, which is the arch of the foot, okay, the plantar fascia and the ligaments. Okay, so you just you just remember the active is the muscles, so the passive is the bones and the ligaments, and then plus the neuro will be all the receptors. So first the patients actually sustain the injury, then we will try to do the intrinsic foot muscles by targeting on active and neural subsystem. This can be doing either using passive modeling, NMES, active assisted, or active modeling. The passive, I mean, we are doing for the patients. Okay, active, the patient is doing themselves. Okay, active assisted is actually assisted by the the neuromuscular electrical stimulations machine or device. Okay, so when they actually already can progress, then they will progress to the integration system, the foot core integration that actually include the functional, standing and loading progressions, and then we have this, we ask the patient to do the sport-specific training, increase the demand, and also increase the sensory neural control. And then if the patient respond well, so what does it mean by respond well? Able to retain the foot core control, the symptoms of pain and dysfunctions is reduced, and able to have a self-reported good score in pain and functions, then we can continue with the integration progress to a full return to sport and activities, and we continue again, everything that we do, we always have to evaluate that, okay, the isolation ability, okay. When you already go to integration, always evaluate that all the intrinsic muscles is it still okay. Okay, then we progress to return to sport or participation. However, for the non-responder, if let's say they still have persistent pain, swelling, and you give the reported score is actually low, actually still in dysfunction phase, then we have to consider a passive subsystem support by either prescribing a orthotic or extrinsic muscle relations and trainings. That means we have to train besides the intrinsic muscle. The extrinsic muscle will include all the peroneus, longus, brevis, anterior, the tibialis anterior, posterior, okay, all the extensor digitorum, okay, the extrinsic muscle. Okay, sorry, and continue the foot core isolation and evaluations of the progress. Okay, this is a complex model, but I find it is actually quite relevant. Okay. Then the phase 3 will be the sports specific. So the goal of the sports specific is mainly we want to go into the specific sports training. So at this moment of time, we want the athletes to achieve a good amount of strength and muscle endurance, neuromuscular or neuromotor control, especially the proprioception. So remember when we prescribing strengthening, we have to focus on, besides the intrinsic and extrinsic muscle of the foot, we also have to train the hip and also the core. Anything will be below. Okay, if it involves the ankle, then you have to train the joint above and below the ankle. There's no joint below the ankle, probably all the flanges. Okay, so you are training for intrinsic muscle already. So above, you have to train the knee and also the hip. And core always play an important role, regardless of which part of the body injury. You always have to train the core. Okay? So according to Sachs principle, anyone know what is Sachs principle? No. Okay? Okay, so I don't have to explain now. It's actually system aided improved demands. That this actually means we will actually prescribe the strengthening exercise according to the patient response. Let's say we do a leg press, okay, 50 kg leg press and 10 repetitions. If the patient unable to complete and complain of pain, that means we have to reduce either the repetitions or the weight. Okay, so this is according to the 6 principles. And encourage full weight bearing without ankle support. At this phase 3, we have to ask them not to wear any ankle wrap at all, because there's tendency patient will wear ankle wrap whenever he goes for any competition. You realize that? This is actually not good, because this will actually cause further muscle wasting, further muscle strength reduce, and also it's difficult to gain. It's easier to end up with muscle atrophy. So we don't encourage wearing any ankle wrap or ankle brace during competitions. And if he's already into the sports medicine phase, ask him to take out the ankle brace, not prolong wearing. Okay. And neuromuscular control exercise, perturbation, and then the sports specific. Like if it's the football, you actually train the agility by using the ladder. Okay, then we have return to sport phase. Okay, so return to sport, always remember there is return, it's a continuum. We will return to participations or training first, either partial or full training, contact or non-contact, and then return to sport, can be half match or full match if it's footballer, okay, and return to performance or pre-injury level. This is the most difficult that most difficult to achieve, and most of us tend to ignore, and patient will be very frustrated and unable to perform, even he able to play. Okay, so we have to try to educate patients and try to have agreements to ask them to comply to the physiotherapy and rehabilitation until they are able to achieve the pre-injury level stage. This is what we aim for. Okay, not stop at pain-free. We want to back to the performance. Okay, this is what sport medicines, and I think all the physio should look ahead. Okay, we are not treating patients, just reduce the symptoms, pain-free, they're able to function, that's it. No, we want to enable them to play the sport and perform as they before the injury. Okay. So phase 5 is the prevention stage. So this is where we will look into specific training on the tactics, skill, drill, and if a patient has high risk of, let's say, ankle sprains or any other part of body injury, we will target it on individual strength and conditioning on the exercise, and we try to optimize the function and performance, and always come up with a good injury prevention programs. Okay, this one I just showing. This is one of the isokinetic exercise strengthening machines that actually train for ankle eversions and immersions. Okay. So again, criteria to progress for each phase is almost the same. Okay, and it's almost the same for all parts or all joints or all musculoskeletal injuries. Okay, so stage 1, okay, when there is no pain, no swelling, no effusion, full range of motion, we progress to phase 2. So when there is a recovery of strength or range, and also the neuromuscular functions, we can actually progress to phase 3. So when you're able to recover from a sport-specific training, then we progress to phase 4, okay? And then phase 4, the athlete will be able to maintain the optimal conditions and also optimal strength. And then we progress to full functional recovery. So any point of time, if the patient cannot achieve, let's say at stage 3, suddenly there is the pain and swelling will occur, then you have to step down and return to the previous stage and treat accordingly. Okay? You have to give some time, because sometimes if you are pushing too fast, what we worry is in terms of long term, the patient might end up, if it doesn't achieve all these criteria, the patient may end up complications, and there is a higher risk of getting re-injury, and when the athlete is re-injured, there is also higher possibility of getting more serious injuries. Let's say it is a history of ankle ACL tear, then there is a possibility of having multi-ligament tear that involve even calcaneal, fibular ligament, the PTFL, or even there is the possibility of getting the taladome osteochondral lesions. Okay, so we want always ensure the patient already achieve this specific criteria before you progress to the next stage. Okay, that's it for my part. Okay, thank you so much. If you have any questions, I welcome you to email me or you can WhatsApp me, available 24/7. Okay, because I like people, so you can actually just WhatsApp me if you have any questions. So, any questions from the floor? Yeah.
Let's say if we have a previous injury of ankle injury without sprain, maybe 5 years or 6 years before, but still until today, if we play a sport, then the pain is occur when some movement or when, let's say, if we are kicking and the foot stuck on the grass, and then it feel like we cannot bear any weight for some time, 10 minutes, 15 minutes, and then it's getting okay. So how can we do to help to ease the problem?
If the pains, let's say, there's a two possibility. One is the pain is not properly healed, it's not well healed, and develop into a chronic pain. And the second one is the patient is not treating adequately. So if it's 5 years and then the patient still having pain while doing the sports or doing specific exercise, I would actually re-evaluate and then we investigate that. Okay, and probably we're not sure why is it taking so long, and the patient is not still having pain. So I will probably look into to further investigate by doing imaging and then assessment and then and also look into if it's the assessment everything seems okay, the MRI show there is there's no lesions, then you have to look into the the just now the bio, psychosocial and the contextual model, the other aspect. Yeah.
Then let's say in terms of the sport, when he still want to do the sport, do they need to wear the like strapping as a protection?
Okay. Sometimes patients actually don't feel the taping helps. This we cannot if the patients, the athletes actually like it and they feel confident with the taping. I'm talking kinesio tape, not rigid tape. Okay, kinesio tape that actually do provide some form of proprioceptive effect. That means they will actually feel something is sticking on there, then they will be more conscious when they're doing certain movement, then you can actually tape, there's no harm. Okay? But rigid tape, we actually need the athlete's movement. So if it's not acute cases, we don't do rigid taping. So initial tape, if the athletes like it, there's no contraindications, it doesn't cause allergies, then you can actually go for that. Yeah.
Thank you.
Okay, thank you so much.
Hello? Okay, thank you, Dr. Chung. So we'll move to the next speaker.